Welcome to the All Things AI podcast. My name is Ishan, and this is the 20th episode of the All Things AI podcast. Today, we have here with us Dr. Satish Vishwanath, an associate professor of biomedical engineering at Case Western Reserve University. His research is based on the application of artificial intelligence, radiomics, and machine learning for disease characterization, as well as predicting and evaluating disease response via different imaging modalities. Welcome to the channel, and it's an honor to have you here today.
Thanks a lot, Ishan. Very happy to be here.
I'll just start off by asking, how's the work in the lab going recently?
It's been going pretty well. We've had some good success in terms of both funding, publications. We've had a number of conference presentations recently as well. And of course, you've also been a member of the group, so it's been a real pleasure having you contributing to a lot of these efforts.
Yeah, perfect to hear that. And I just want to ask more about that, I guess, in today's first portion of the interview and really dive into what's been happening recently. So the first portion of today's interview is going to be dedicated to your work as a researcher at Case Western. I'll just start off by asking as an icebreaker for this, what's your current research focus and what are you looking to explore in the future in the intersection of AI and healthcare?
Sure. So the current focus of research in the group, like you mentioned at the start, has really been trying to develop new artificial intelligence, machine learning, radiomics, image analysis, pathomics as well, approaches to try and characterize disease, to try and evaluate response to different therapies, predict response to different therapies. Kind of the mandate that we take going into all of this is that there is a lot of information that is present in the different types of imaging modalities that are being captured about from patients in clinical workflows. And is there a way we can try and use that information, extract it, make it available to clinicians to try and inform the process of deciding what kind of clinical intervention should be done for these patients, whether it's the medication, whether it's surgery, whether it's follow-on therapy. How should we be following and tracking these patients, and how do we inform that process using advanced AI approaches?
Yeah.
Um,
And so in that, do you guys make like the process more efficient? Because I know that's one area of AI, especially looking at from personalized healthcare approaches, that when you apply AI to healthcare, it can make everything more efficient. So is that one of your goals?
Efficient is an interesting word because efficient has different meanings depending on whether you talk to whether when you talk to, let's say, you talk to the radiologist or the pathologist, their definition of efficient is very different from, I suspect, if you were to talk to like the administrator or if you were to talk to the insurance company, right? Like these people, not that they don't agree on some aspects, but they also have certain things that they all focus on. I would say we are trying to make it more effective. I think that might be a better place that we're trying to go towards. One of the ways, looking at this in a few different ways, one is there a way to make the AI approaches themselves more effective, right? Can we design AI approaches in such a way that we're capturing the information that is actually important, relevant, can be, is intuitive in some fashion, right? That's one angle. So can we make the approach is more effective, and then can we actually make the clinical decision making process more effective? So by making available information that clinicians don't currently have access to, maybe their decision making itself becomes more effective.
Yeah. And as far as information that physicians don't have access to, could you describe an example of that currently and what that would look like?
Sure. So one of the big foci in the lab is in the context of rectal cancer. So rectal cancer are basically tumors that grow around the rectum, and they are fairly aggressive. There's a pretty robust treatment protocol for these patients where they undergo pretty aggressive chemoradiation, uh, often undergo chemotherapy even nowadays, and then they go to surgery. Right? This has sort of been the standard for about 10, 15 years now. One of the things that they've realized, though, is that a lot of patients who are getting surgery for rectal cancer after this treatment very often don't have any tumor remaining in the rectum anymore, right? And it's not metastasized anywhere else. So what that means is that potentially these patients could have avoided the surgery. And there have been studies done where they followed patients without doing surgery on them, and they found that it turns out that their survival is about the same, but their quality of life is way improved because this
Yeah.
is a pretty aggressive surgery. You're taking out the entire rectum. Right?
Yeah.
So now, today, the world we're in, the clinical evaluation for rectal cancer does involve a lot of different facets, right? They look at endoscopy, they have a digital rectal exam, they have MRI scans that they're doing, they're looking at serum markers, but individually, all of these are not quite capturing all the information the clinicians need. What they want to know is the tumor dying up, right? Is there more fibrosis or is there more tumor? These are the questions they want to know. But the way we are dealing with these modalities today, they don't have access to all of the information. So they kind of have a reasonable uh, assessment, but they don't have all the information.
Yeah.
And so one of the things we're trying to do is there a way for us to leverage the MRI scans that they're already capturing as part of standard of care and
Yeah.
go in and start to derive signatures of that response so that now they have a much better sense of what's going on with these patients, right?
Yeah.
Um,
And would I be correct in saying that deriving this is particularly something that AI is good at, that you can't find out without AI technology?
um, I would say that I would phrase it slightly differently. I would say maybe that AI is showing a lot more promise for extracting these markers, right? Because there are multiple ways we could try to capture this information, and there are lots of ways being explored in this field right now. So AI is one of these tools in the arsenal. But I think one of the big things that we are bringing to the table here is the fact that we're building this in a very complementary fashion, right? So if we're adding in two other modalities and that's somehow boosting the performance of identifying patients who have response, then AI could potentially boost that just a little bit more or boost the confidence a little bit more.
That makes sense. And I think with AI being possibly the greatest technology, especially in the recent times with the speed that it's developing at, it's definitely going to be a great tool to physicians as they go into the future. So with that being said, I also want to look into some of the recent research that you've been exploring out of your own work, for example. And so in that, what are some innovative discoveries that you've seen in the conferences that you've attended or even the papers that you've looked into?
Sure, it's a great thought exercise. Um, so I want to say over the last couple of years, um, there's been massive interest and massive influx of these large models, which now we're starting to call them foundation models, right? Um, and I think we're just sort of scratching the surface with what we can and cannot do with foundation models, right? And there've been some really fascinating papers that have just come out in the last month or so where they've started trying to build these foundation models for medical images, right? And this is tricky compared to natural language or natural images and so on and forth, because medical images are not nice and clean and clear as to what you're looking for, right? You don't have, oh, look, the mountain is very different from the tree. Now you have a bunch of nuclei in a tissue. It's very messy. You take MRIs, it's like, oh, if I squint this way, that is dark enough that it's muscle. If I squint the other way, that's dark enough that it is not muscle, right? So a lot of evaluation and expert knowledge needed to even understand what's going on with an MRI or pathology image or a CT or whatever else you have. So I think we're reaching the place with the data, with the models, where we're starting to scratch the surface with what we can do with foundation models in this space, where we're basically building models that are kind of pan disease, right? So we're able to take in a lot of different types of images and start to capture underlying tissue types or tissue structures or regions and so on and forth. And where I think this is important is it's going to kind of it could simplify some of the pre-analytic steps that are needed, right? Like we need to go in and find regions in an image. Well,
Yeah.
is there a way for us to do that by actually accumulating information from across a lot of different? That said, this is literally cutting edge. This is literally research papers that came out, like a month ago. So if I was to go a little further back, I would say so I think some of the groundbreaking stuff has probably been in the kind of the whole inception behind the kinds of things we can do with the digital pathology. I think we've seen a massive explosion on that front over the last 5-10 years now. And it's been fascinating to see that field evolve very,
Yeah.
very rapidly. Right? They started out with just, can we find nuclei? Can we find cancer? And now they've kind of pushed past it. They're like, can we find, sequencing information? Can we predict the pathways that might be implicated in a particular tissue appearing in a particular way? Can we look at spatial phenotypes? Can we look at how immune interactions are occurring with tumor? Right. So there's like this very rapid iteration happening of like layers of information that we're able to mine out of tissue samples. From a clinical perspective, makes total sense, right? This is what pathologists and oncologists are doing every day with this kind of data. But it's fascinating to get computers trained so well, trained to the point where they can actually assist in that and start to capture that information more effectively.
Yeah, so I think the whole idea here is that by doing this and then through things like digital pathology, you can really increase the confidence interval that we're going to see so that when pathologists are making a decision, they can be like 100% reassured that they're doing the right thing. And would I be correct in saying that?
Yeah, and I would say it would also, so there are kind of it kind of have an effect in two different ways. One is it is allowing them to sort of hone in on the regions they need to be paying attention to, right?
Yeah,
Because these are massive, you have hundreds of tissue samples, massive images. How do you know where to look? So
yeah,
it
exactly.
can help with kind of helping them look where do they need to look at. And then to your point about confidence decision making, it's trying to derive measurements that can be used to inform the decision making process and boost the confidence.
Makes sense. And one of the other things that I wanted to focus this portion around was digital pathology itself. And then one specific question, what are some challenges that arise in this process of digital pathology, especially because I know that even from the perspective of the physician, it's not always easy to decipher exactly what's going on in a certain slide, histology slide, and how to segment that.
Uh, I mean, I think the challenges. I mean, there are lots of challenges we're still overcoming, and we still need to come up with ways to handle them in a consistent fashion. I would say, um, it starts at the very beginning. You have slides which are being prepared. Are they being prepared in the same way? If they're not, like what is different between them? Right. This question of um, garbage in, garbage out kind of extends across all of medical data, right?
Yeah,
And for the most part, we have been building models with the data we have, not the data we want,
makes sense.
right? So what I
Yeah,
mean by that is, the medical data is very scarce. It's a very sort of valuable resource because it's very hard to curate large cohorts of information with everything you need. So now how do we so we have to collect all of that data. Then we need to make sure we have all the information we need for those patients. But so we very often end up with cohorts, but it could be that there are, pathology slides in there which are out of focus when they were scanned or they're cracked or there's some preparation issue, which is a minority of slides. But when you're dealing with smaller cohorts, the minority of slides suddenly becomes a bigger problem. Right? And the same thing extends across other modalities. The same issue happens in MRI scans. You can have artifacts, you can have ringing, you can have shadowing artifacts, CT scans, you could have metal artifacts or reconstruction artifacts. The when you see all of these things and every time you run a model and it kind of breaks, does not work as well on an image like
yeah,
these, you suddenly realize just how powerful the human eye is because pathologists and radiologists are dealing with this every day and they just kind of they're able to look past the artifact and they will actually see the signature.
yeah,
But even the slightest change and the machine is suddenly like, I have no idea what this looks like. This is not anything I've ever seen before.
yeah.
So I think the data is probably one of the biggest problems we're facing, and we're still coming up with ways of how to handle data correctly and make sure it's not getting messed up in our processing of it or analysis of it, so on and so forth. And then I'd say maybe broadly the concept of knowing or designing the model to in such a way that we are able to understand what kind of information it's capturing,
That makes
right?
sense.
Whether it's whether it's a let's say what they call a handcrafted feature where you're going in and looking at interplay of particular types of nuclei or particular organs or whatever it may be, or you're using the deep learning approach with the large neural networks and you're trying to figure out you're giving it a ton of data and it's learning the patterns by itself, like the foundation models we were talking about, right? In all cases, the question is to me very often is, do we know like what this model is even capturing? And one way to think of it is, do we know when the model is going to break?
Yeah,
Right? If we don't know when the model is going to break, we have a problem.
exactly.
So
Yeah.
yeah.
And I think data shortages are something that I can connect to myself. Because before I did independent research myself, and I still do sometimes in my own free time. And one specific case when I was dealing with medical data specifically was in my freshman year when I was doing a research project to predict pulmonary hypertension using ECGs, which are time-based data, and using convolutional neural networks to do that. And one thing that I noticed was that publicly available, there's only like 200, 300 samples for certain certain, like, I guess, conditions. And so the way that I combated that specifically was by using data augmentation, by like adjusting like the frequencies and the noise and things like that, because obviously it doesn't give you the best data, but it gives you more data to work with and cases that the model could see. So I was wondering from a research perspective, because obviously the models that you guys make have to be top notch, especially considering that they might be employed in the clinical world in the near future. I was wondering how you guys deal with data shortages, and especially when they happen, what steps you take to mitigate them.
Yeah. I mean, the techniques you mentioned are probably kind of I would say the standard that you should be using from a best practices perspective, right? So
Yeah,
data augmentation, oversampling, maybe undersampling in some cases, depending on how large your cohort is, um, uh, are the classical approaches to addressing the problem, right?
yeah,
But we know from our research and from our analysis and the studies we've done that at the end of the day, data augmentation only goes so far.
yeah,
Just like with any other sampling technique, you are limited by the data set that you are sampling from, right?
yeah,
And the real world, unfortunately, will have variations that do not exist in data set. No
yeah,
matter how extreme you make that, right? Like we've done it where we've taken it to ridiculous degrees of noise and variation. And then we'd say, oh, this model looks pretty robust. And then you find a scan from a totally different institution, and suddenly, guess what? It stopped working. Well, why? Oh, well, this is the one variation which we cannot simulate, right?
yeah,
So uh, I would say the oversampling, undersampling, being kind of rigorous with the way the training, validation, and so on are done in such a way that you can get robust estimates is probably what you have to do when with the data you have, right?
yeah,
The good news is that between a number of different agencies, between all the efforts ongoing in the space, the the amount and volume of publicly available medical data is going up. Right, they have massive resources being dedicated toward it. So that's great. That means that there is light at the end of that tunnel. There is a likelihood that over the course of a project you're going to be able to get access to hundreds of new scans which you wouldn't be able to get otherwise. And it's happening. It's not like it's concentrated. Or this cancer everything is available, but then you go to the
yeah,
other cancers like 2 days. It's
yeah,
actually kind of growing in different cancers and different conditions even to a fairly robust degree. So all of that kind of gives you optimism for hopefully the data shortage is less of a shortage in
yeah.
the future.
And I definitely think as we continue to collect more patient data, specifically because now we know that we can be using this data to develop things like AI models, it not only makes sense to collect data as much as possible, but also because it can solve things like variations, especially if it's a rare case of a certain syndrome or disease or cancer.
But
Um,
but but I smile because the we're kind of in the nascency of the space, right? With data collection in the medical space, right? And if
yeah,
you look at parallels in other areas of the world, social media, for example, now we're in a point where a lot of places are like, no, we want to make it easy for people to take their data out. So now suddenly
yeah,
you have to kind of we have to come up with a balanced approach. Right? I'm not saying that one way or the other way is better or worse, but this is something to keep in mind. Yes, we should be collecting this data. Yes, we should be trying to use as much data as we can for research. But how do we do it in a way that actually respects the fact that in the
exactly.
future it may be that you want to, you that at the end of the day the individual should have control over
Yeah,
their own data, right? And this problem starts, if you think about it a little bit, it starts to become a question. It starts to affect questions of representation, of equity. Like there are lots of little pieces to this that we're not quite ready for. We need to figure this out. Right? This is kind
yeah,
of where we need to be going, right? But it is important to keep that in mind because as an AI researcher, I would love it if everything was available for
yeah.
training a model. But on the other hand, as an AI researcher, I'm also cognizant of the fact, well, if everything is available, guess what? There can be issues with that approach too.
Yeah. And no, I think that that's definitely a great point to make because I haven't seen this specifically from the patient perspective, but like we've seen OpenAI in the New York Times lawsuit, for example, a few months ago. And that really shows that people do care about their data. And you gave the example of social media and the internet. So I think that ties perfectly into that. And I think that data ethics, it's like a whole nother ball game from the research itself. But I think they definitely need to work together. We need things like data ethics officers or people like that. And I know like the state of Ohio itself, I was looking into some legislative research from like the state government, and there I think it was policy IT 17, and it's specifically looking into appointing like a chief data officer council so that they can vet
Mhm.
things the state is specifically doing. I think if we spread practices like that into like the healthcare itself, then we can assure that everyone is going to be happy with whatever's getting shared around, while also assuring that we have the most data possible.
Absolutely. The so recently NIH has instituted a policy called a data management and sharing plan. Right. So all funded projects by NIH across the entirety of NIH are expected to put together this document explaining what kind of data they're generating in their project, how they're going to make it available, what format, what standard, like a lot of detail is in there, right?
Yeah.
Which is a great step to take, right? You're kind of forcing people to think about how am I going to make this data available for future research, which is great. I also know how much time and effort it takes to do that. And then I have to start to look at what are the resources we have to actually make the data available, right? So like I said, there are lots of little details in there. I like the idea of having, like you said, the data or the ethics officer, the data officer. I like the plans. I like all of these things. But and my thought is always, okay, we're doing this. This is all great as a first step, but how do we keep it as a sustainable, ongoing process, right? That's gonna really have the impact we want it to have.
Makes sense. And with that being said, I want to take a couple of minutes just to look at a broader exploration of AI in healthcare, aside from things like pathology and radiomics itself, and take a look at things like the personalized healthcare revolution and then research in itself, the process it is. So the first question is, what role can AI specifically play in the personalized healthcare revolution?
So I think it's it's becoming clearer over time that AI can help inform decisions with regards to um, how effective a therapy is or what kind of therapy a patient could be given. Right. I think it's becoming clearer. I'm not going to say it's a slam dunk yet. We still have to do a lot of validation. We need to do the clinical trials and all of the work, legwork still needs to go in there. But I want to say that, in terms of personalization, AI is definitely on the right track for helping impact those areas of the clinical workflow. How exactly it gets integrated, at what point it's invoked to help make that decision, and so on, are things we still need to figure out,
Yeah.
right? But it definitely looks like one of those tools in our arsenal that's going to help address questions related to how do we decide the therapy, or how do we decide to switch therapy, right? And these are really places where I want to say we still have massive challenges with existing modalities in different ways. Right? Every modality that we have today, it's not like it is. They all have some limitations, and maybe bringing AI in there could help overcome some of those limitations.
Yeah, that makes sense. And I also want to take a look at the research publication process in this quickly. I know you're a researcher and you've published a bunch of papers, helped PhD students, undergrads, and everyone publish papers and really get into that process of research. So what does this process look like of research from start to finish when you pick up a project idea, start getting into it, face some challenges, and then really submitting it for things like, I guess, competitions or
So we've touched on some of it
yeah,
throughout our conversation today, right? I think getting into a project, usually before we even start talking about anything else we're doing, the first question to me is very often, what is the impact? Right? What is the question that really matters in this space? Because sometimes that helps kind of focus the project on the finding that can actually have, right?
yeah,
Because it's part of the brainstorming process, right? Because like I said, there are multiple problems involved in the healthcare process. So which one are we really trying to target? Do we have the data to target that problem? Then that helps kind of crystallize how do you design the project? What are the if you're doing some kind of prediction or progression or evaluation, what is the endpoint you're going to look at? What is the data you're going to use? So on and so forth. Um, I would say so that probably takes that probably requires the most thought and kind of finessing to understand it as deeply as possible. Um, and that involves talking to folks from multiple disciplines, right? And these are all things that we try to do in the lab as part of projects that everyone is pursuing. We have we try to ensure that we are talking to all the stakeholders in the game, because it's possible that there's a problem faced by someone in radiology which could be addressed by something being collected in pathology already. So then the question is, okay, what are we, which additional piece of information are we missing that we should be bringing to the table using these AI approaches? So that takes a large amount of time. Then from there, we have to move on to the nice thing is that the rest of the next few steps kind of follow from this first brainstorming process of defining and determining the impact and significance. So figuring
Yeah.
out the data, figuring out the sources, and so on. And then from there, you get into more of the details of how do you design the AI system, how do you evaluate it, how do you validate it. The publication itself is kind of your milestone marker along the way, I would say, in towards this larger problem, and over it really needs to be driven by two questions actually, which you define over the course of the project. One is this question of the clinical need and impact, and then the hypothesis, like what exactly are you testing in what fashion in this study. And sometimes you end up starting a study without having complete clarity on the hypothesis, but it is something that needs to be defined as you get closer to your mile marker, right? Because it can't be a fishing expedition. You need to be saying, I'm testing this particular type. I'm testing this AI model for capturing this type of information with these assumptions. Like you have to have something defined.
Now, this all makes sense. And really to tie everything off, I just want to ask one question. And ideally, now I'm saying ideally by starting this off because obviously everything isn't going to go as we want to in the next 5 to 10 years. But how do you see AI impacting healthcare in general? And what would you like to see as far as AI maybe helping physicians in the future, new discoveries? And from that perspective, I'll just leave it open, I guess.
So AI impacting healthcare in general, I would like to say that over the next 5 years, 6 years, we're going to start to see the first results of, hopefully, we're going to start to see the first results of AI being used in clinical trials in some fashion, right? As an endpoint in a clinical trial and showing that it is effective for the purpose it was designed for, right? That's kind of one of the hopes I have for it. We have AI being validated on clinical trial data sets, but I'm
Yeah.
talking about actually using it in the trial, right? So I'd like to see us getting there over the next five or so years. In terms of longer term ideas of where it could go, where it could be, the fact is, we are kind of at the very beginning of this massive change that we're trying to invoke in a very critical system, right?
Yeah.
So I feel as though there are lots of pieces that we are still yet to think about when it comes to some of this. So, one of the things that I realized just recently about, maybe like just a month or so ago, as part of some of the work we're doing is that, hey, guess what? We've been developing some really sophisticated AI models, but they're being developed by engineers for engineers to look at and presented largely to engineers.
Yeah.
What if I want to show it to a radiologist? Like,
Exactly.
what do they want to see? Right? Suddenly that opens up a whole new area of how do you design AI models and develop them, present them to clinicians. So I'm not talking about assisting the clinician. Right? That's fine. That's a prediction or a probability or a likelihood. But how do you actually present the information? That's a whole other ballgame.
Yeah.
But this is being figured out. We don't know. This is a question that is being figured out by a lot of people, very smart people altogether. So
Yeah.
I'm hopeful we see this getting integrated very deeply into the workflow, right? It needs to become, my favorite example of this is we all have a robot, or a lot of households in the US have a robot in their kitchen every day. Nobody thinks of it as a robot, but everyone has it, and a lot of people use it every day. And it's your dishwasher. The dishwasher is a washing robot, right? That's the level at which AI has to be integrated into the workflow. It needs to be like a thing which is just there, and you don't even think about the fact that you're using it. It's just part of your tool. And that's where we need to get to, and that's when we've really changed the whole paradigm of what's going on here.
I think transitioning from R&D or research and development to really applying AI is going to be definitely the next big thing that we have to look forward to and to see how it's going to get integrated. And I think it really offers great potential. And I like the dishwasher example that you gave because I think Tesla is doing something similar to that, where they're going to release a bot. I think it was in the five figures, but basically where somebody can do things at your house for you. And I think that's just testament to exactly the impact that AI is going to have in the near future.
But the example you gave is a very good one because we already built the dishwasher. We have it.
Yeah,
It's doing a great job already because it's a very, very specialized robot.
exactly.
The minute you build the general purpose robot, the way Tesla is trying to do it, or a number of other companies too, suddenly it gets much more complicated, right?
Yeah.
And that's pretty much the story of AI as well. If we're trying to build very, very purpose built AI, I'm sure we can get that done for basic tasks very rapidly. We're trying to build generalized, this AI that can do all sorts of amazing things at the same time. That's the much harder problem.
Makes so much sense. And I really think that's a great way to cap off today's discussion. So thank you so much for your time today.
Absolutely. Thank you.
Of course, yeah. And for everyone watching this, make sure to leave a like, subscribe, and comment down below.